TopMedTalk.
Well, I'm Desiree Chappell, co-editor-in-chief and host here at TopMedTalk, and joining me today is former editor-in-chief, filling in for editor-in-chief Mike Grocott, Monty Mythen.
Good to be back in the jump seat, Desiree.
It is. I had to mention Mike because we haven't talked about Mike very much. To say,
when I joined Edwards Life Sciences last August,
yes,
I handed over the editor-in-chief position to be co-editor-in-chief with you to Professor Mike Grocott.
That's right.
Professor Mike Grocott.
Yes.
And I'm still emeritus professor at UCL and adjunct professor at Duke, so everyone's decided I can still jump in occasion.
Yeah, it's all good. Well, we thank you for joining us here at the meeting. But this is kind of where we got our roots. We would go to smaller meetings and have conversations with key opinion leaders, presenters, attendees, and hear about the conference. It's been a fantastic meeting, hasn't it?
Very rich pickings.
Yeah. They are. They're so wonderful. I love it. I know. It's the best kept secret in anesthesia.
Don't tell. Let it get out.
Well, true to TopMedTalk Forum, we are here in the exhibit hall having conversations again with all the attendees here at the meeting. And our next guest is Dr. Caitlin Sutton. Caitlin, thank you so much for joining us.
Oh my goodness. Thank you so much for having me for this conversation. So excited to chat with you both.
Yeah.
Hey, then we met at the World Congress recently.
We did, in fact. I saw you there in Singapore.
Caitlin, why don't you introduce yourself? Tell us a little bit more about where you practice and what type of anesthesia you do.
Yeah, thanks so much. So I actually am dual trained in pediatric and obstetric anesthesia. And so I lead the Maternal Fetal Anesthesia division at Texas Children's in Houston, Texas. And so most of my practice is doing anesthesia for fetal surgery there.
Oh, fantastic. Where did you train?
So I did my residency at Emory. I did my OB fellowship in California at Stanford, and then I did my peds at Texas Children's in Houston.
Fantastic.
Kind of zipping in.
Yeah, a little bit everywhere.
I want to dive straight in this. Anesthesia for fetal surgery.
Yes.
For everyone, a very broad audience here.
Yeah.
To a lay audience. Talk us through that one.
Yeah.
What's fetal surgery?
Fetal surgery. So fetal surgery is what we do when there is a fetus who is diagnosed with some congenital anomaly. So a baby that's still in the womb, a woman is pregnant, baby's still in the uterus, and it needs surgery or an intervention before it's born. That might be in the middle of gestation. It might be right at the time of delivery, but it happens before it's born while it's still in the uterus.
Wow.
So who are you giving the anesthetic to?
Both. That's why I had to do 2 fellowships.
Oh my gosh, that's incredible.
Yeah, so we usually, depending on the case, we often have 2 anesthesiologists, one for mom, one for baby. Actually, on our team, everyone is dual trained, so we don't really divide it like that, but you have people who are taking into consideration both of the patients, sometimes 3, sometimes 4. I have triplets.
Oh yeah.
I'm going to be very dumb here, but the mum's sharing the anesthetic with the baby. You directly give an anesthetic to the baby as well?
Yes, that is not a dumb question. That is an insightful question, actually. So we give anesthetic to the mom. Of course, a lot of things cross the placenta. Almost everything crosses to a degree. But we also do give direct anesthetic to the baby. Usually what we do is we prepare the medications, then we sterilely give them to the surgeons. And so then they administer it usually intramuscularly through a long needle. But it is the only setting in anesthesia that I can think of where you have to depend on your surgeon to give the anesthesia for you. Yeah. So you need a lot of trust, a lot of collaboration.
Wow.
My mind is racing right now with all the different questions about what this looks like. And
so do you tend to do the mums or the fetus, or do you mix and match?
Mix and match. You got to keep it
interesting.
Keep your hand and everything. But really, what we do with our group, we don't usually divide it between one or the other. Most of those surgeries, one of those patients, either the pregnant patient or the fetus, is going to have kind of a more intense anesthetic, and then we'll focus on that. But if you end up having something go wrong with one or the other, then we kind of divide so that we can keep our focus. A lot of our pregnant patients are awake during the procedures. And so a lot of it will be kind of one person is focused on communication with that patient so that they can stay on board of what everything's happening as well.
And some people may have seen this up close and personal. I'm guessing you've all seen a bit of it on the news or documentaries or the suggestion that it's possible. But it's becoming quite common now, is it?
Depends on your definition of common. I will say I don't watch Grey's Anatomy, but I heard that there has been some on Grey's Anatomy. So I think that means we're making it into the mainstream.
You probably don't want to watch it because you're like, that is not how that happens.
No, but I think, there are big fetal centers that do a lot of this, a lot of volume. I think we're one of the bigger centers. There are centers across the world. And then there's a lot more centers that do, minimally invasive, smaller types of surgeries, but a few places that do a lot of them.
And what are the common ones now? What are the common surgeries?
Yeah.
I guess it's crept into the exams now for anesthesia.
Yeah.
Common fetal
Exactly.
surgery.
Yeah. So if we kind of divide them into a few groups, so the minimally invasive ones, probably the most common is laser of the placenta for twin-twin transfusion. So when you have twins that are sharing a placenta, then you separate it using laser. Probably one of the more common ones that a lot of people think about that's a bigger surgery is spina bifida repair. So we'll repair that kind of mid-gestation, so around 24, 26 weeks, and then hopefully the mom stays pregnant for a few more months before she delivers. And then exit procedures, which are kind of like a modified C-section where the baby needs some sort of intervention to make that transition from a fetus to a neonate. And so we do a kind of a modified C-section where you say it's an airway problem, deliver the head and shoulders, do either a tracheostomy, something like that, and then deliver it the rest of the way so that it's still on mom's support getting oxygenation while you're doing that intervention, so they do better as far as during that transition.
So for those of us who are not in this space at all, when you say minimally invasive versus, you explained it, you're in a C-section scenario, essentially, for the major complex procedures. What does a minimally invasive surgery look like?
Yeah, so it can be usually two different ways. One is kind of a needle, ultrasound-guided needle-based procedure. So just have an ultrasound like a patient might have while they're getting their regular anatomy scan, but they use that to guide a needle. Maybe the baby needs a transfusion. And then the other type is when we place a fetoscope. So it's a small port that we place in, and then you have a small camera, the fiber optic scope, and you can have a working port. But both of those are so minimally invasive that you can do it with just local anesthesia and sedation.
Oh, wow. And so I'm sure this space is, going.
Oh, yeah. It's exploding.
Exploding, yeah. So, do you think that we're just kind of at the tip of the iceberg here? And
I really do. A lot of this is driven by we're only now able to diagnose these things, right? Because our imaging is becoming so much better and our patients are getting ultrasounds, whereas, when I was in utero, boy, girl, kind of a guess.
Yeah, exactly.
But now we can diagnose it. So as technology improves, we can diagnose things. And then there's really important ethical questions around it, right? So we only would do this if it's something that's going to improve really severe morbidity or mortality. So it's really something that there's a reason and there's a benefit to doing it because you're involving the pregnant patient, right? Who is going to be at some risk anytime you're doing anything.
Yeah. Robots. Have the robots arrived?
Such a great question. So this is just kind of, people are beginning to look and see, okay, are these robotic tools going to be helpful from the getting access, getting visualization? I've heard, rumors, I always say I can't anesthetize a rumor, so I can't make any statements, but I have heard that people are starting to bring that into this space and see if that's helpful. The trick with this, and let me say I'm not a surgeon, but one of the tricks in watching all of these is that the position of the baby. And with robotic surgery, the position and, docking and everything is so important. Almost the most important person in a lot of these surgeries is the person who's holding the baby in a position, and that makes the robotic stuff harder, but it's still, I think it's coming.
The robot hold the baby?
I know, that's what I was thinking.
The robot could hold
we're getting way off piece there, but it's amazing.
I love it.
So what are some of the newest and latest, greatest research or evidence, that we should be looking at to learn more about?
Oh, great question. So there's a lot of movement towards trying to make these bigger surgeries like the spina bifida ones, which started as open surgery. So if you can imagine kind of like you open the abdomen, you open the uterus, you do the surgery, you close the uterus, you close the abdomen. So there's a lot of morbidity with big incision on the uterus. A lot of things are now trying to move to more minimally invasive. So for example, the way we do a lot of our stuff is called fetoscopic. So we may open the mom's abdomen, but then instead of opening the uterus, we put ports in the uterus. So that way, even in that same pregnancy, she can deliver vaginally. And so that decreases the risk during that pregnancy, during all her future pregnancies. So I think where we're going, where we need to be looking is how can we minimize the risk for the pregnant patient as we try to gain benefit for the fetus. And so the more fetoscopic procedures, the more minimally invasive stuff we can do, the better.
Yeah.
And I'm guessing, like all forms of surgery and intervention over time, that the more people try, the better they're getting, and the results are getting better and better. Otherwise, you tend to stop.
Exactly.
Eventually.
Exactly. And there's been a lot of that in fetal surgery. You know, the first things that people tried, doesn't necessarily work. And so the way that, for example, for congenital diaphragmatic hernia, the first things they did was they tried to do a primary repair. And now we do something completely different. We don't try and do a primary repair anymore. They place a tracheal balloon, a little tiny balloon to block the trachea in the baby, place that early in gestation, or not early, kind of mid-gestation, and then take it out before the baby's born. That's not a primary repair at all, but we're looking to see, is that helping with decreasing the severity of morbidity for those babies.
And you touched on it in the decision-making.
Oh, yeah.
Because that's obviously very, very complex. I'm guessing it's multidisciplinary. Harm to mum.
Yes.
And how mum risky is it?
Oh, Monty. I'm an ethicist, what I do occasionally. So this is a really, really, really important avenue for me. So it depends on what types of surgery we're doing, right? If it's minimally invasive, the risk physically is really low. That being said, at this conference, we've been talking a lot about trauma and the trauma that comes with a complex pregnancy and then having to undergo this. So I don't want to say it's really low risk, because there's a lot of risk for trauma in these pregnancies and these complex pregnancies. And so we try and do what we can to prevent that. But those are, from a physical standpoint to the mom, the risk is really low. It's actually quite safe when you look at the data for the mid-gestation surgeries that are even bigger surgeries under general anesthesia. We use epidurals for post-op pain. Still, they do quite well. There are some kind of particular things that they're at a little bit higher risk for, pulmonary edema, that sort of thing. But what I think really matters is patient selection, but also, as you mentioned, decision-making. The patient needs to have extremely thorough understanding of everything that's encompassed in this experience. What's the recovery going to be like? What's the rest of her pregnancy going to be like? And what is the alternative? Say it's spina bifida. What's the difference? What's the benefit of doing this now versus doing it when the baby is 1 day old?
Yeah.
I guess there's loads of people now who want to read a little bit more about it or see something a bit more about it. Any particular websites or recent articles or review articles or something that they can get a quick grab?
Yeah, absolutely. So we're doing this interview just a little bit too early for me to give you this info, but there's a recently formed society, the Society for Maternal Fetal Anesthesia. We don't have a website yet. It's currently being developed.
Yeah.
But the Society for Maternal Fetal Anesthesia is kind of an even smaller society to bring people together who are interested in this. And we've had a few annual meetings. So there's a lot of interest in that space. You can email maternalfetalanesthesia@gmail.com and reach us. And then once we have our website up and running, but there's a lot of information out there about fetoscopic surgery. Our hospital in particular has all of our outcomes and volumes on our website at Texas Children's Fetal Center. So a lot out there to see.
Tell us a little bit about your involvement in SOAP and this thing called SOAP Speaks.
Yes. Yeah. So SOAP Speaks. It's a database. It's a tool that we have developed. It's kind of under the auspices of the Inter-Society Committee at SOAP, but it was really something that was wanted by both the board, the powers that be at SOAP, but also SOAP members. We had been hearing for so long, it's really hard as a member to kind of level up to that next step. Maybe you've done a grand rounds at your institution, maybe you've done maybe a regional talk, but getting to that SOAP stage where everyone wants to be, the national, the international talks, to get to meet Monty at the World Congress, that's where people want to be. So how do you level up to that next step? It's tricky. And then we heard from curriculum developers, man, we are tired of having the same people over and over, but we just don't know how to make these connections. And the last thing you want is to have people travel, pay money, come across the world in this time where that's such an effort, and then have a speaker that's like not that engaging.
Yeah.
And so we developed SOAP Speaks. And so what the goal is to level up people who are ready for that next stage, but also to increase diversity, inclusivity, representation, and education in OB anesthesia for the people who are applying, and then match people who are passionate about what they're talking about. They're engaging speakers so that the curriculum at meetings, at regional places can be better. And so what people do is they apply for a spot in this database. They send their application and it's reviewed. And then if they are deemed ready, you're either ready or not ready. It's not a yes or a no. So if you're ready, then you go into this database, and then people who are looking to fill a curriculum can log in and they can say, oh, this person has these 5 talks that they want to talk about. And they've been reviewed by a panel of people who I trust, who I know, and they've been deemed to be a super engaging speaker. And so we're not looking at content, we're not looking at expertise, but we're looking at people who are passionate about what they want to talk about and that they're good at communicating that message.
Yeah,
Excellent.
that is very, very cool. And people can find more information about this on the
SOAP website. Yeah.
Where do I apply?
Yeah.
I'll send you the link.
That's awesome. Well, Caitlin, thank you so much for joining us today. It's been a fascinating conversation about the fetal surgery.
Gosh, thank you both for having me. It's such a pleasure.
Yeah, hopefully next time we're together, we can hear more about this and kind of next steps of where it's headed to.
Thank you, guys.
Thanks so much. And thank you for listening to Top Med Talk. And you can find us at TopMedTalk.com. We are on your favorite podcatcher, LinkedIn, X, and Facebook. We are there. And YouTube. If you see this on YouTube, give us a thumbs up, subscribe, support us. Every little bit helps. And thank you so much to SOAP and to all of our sponsors for keeping Top Med Talk free and open access to the world. Cheers, everybody. Thanks.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.